we look at the superior tibiofibular joint, whose articulation angle varies, and its main attachments are the lateral collateral ligament, as well as its capsular ligaments. And one has to be cautious of the nerve coming around the neck of the bone. So identifying the bone and stabilizing the tibia and assessing its motion, which on this model is very loose. Identifying the neck of the fibula and verifying that there is no tenderness or tingling on palpating in the vicinity of the nerve. And then the lateral collateral and the biceps attachment coming into it. These can be differentiated by turning the heel in and the hip out, which removes the biceps tendon from the lateral collateral, and you can identify the ligament separate from the muscle. In order to assess the ability of the superior tibiofibular joint to move posteriorly, we need to set the knee in slight flexion. And as she's very mobile, or if your patient has any instabilities of the knee, stabilizing the tibia is essential. So I'm going to position that very carefully to, no, that worked better that way, to steady the tibia without blocking the posterior movement of the fibula. Now I can stabilize this, and we can see now that we've got very isolated motion of the fibula in this position. So if I felt a restriction to the posterior motion, I could use this as a mobilization. If I needed a little more pressure or force on the position, I'm using my hand to both stabilize the tibia and put pressure on the fibula, and then my left hand is providing the mobilization in a posterior direction on the fibula. From this position, if the fibula was in need of a manipulation to move it very rapidly into a posterior position, again with patient consent and informed what is going to happen, a pre-manipulative hold, specifically looking for local pain through the knee and any sign of nerve sensitivity through the lower leg. If those are negative, the position again of stabilizing tibia, fibula at its barrier, and quick motion to the fibula. To take the superior tibiofibular joint in an anterior direction, we've got the patient prone with the head of the bed lifted to create just a little knee flexion to take the stress off the knee ligaments as well as the biceps femoris tendon. If the knee is very flexible, or if the ankle is very flexible, those areas will be stabilized. And using a wedge or a sandbag to support the foot and to support the tibia and relax there will be very helpful. Again, the fibula is now free to move, the tibia is stabilized, the foot is stabilized, and from here one can see the mobility in an anterior direction of the superior end of the fibula. If this didn't move as well as this and needed mobilization, one could mobilize with the hand, or more comfortably with the thumb supporting the posterior part of the joint and the other hand doing the mobilization. If this required a quick movement, in other words, manipulation, this again would suffice to have the tibia and ankle supported, the thumb again on the posterior aspect of the fibula head, everything stabilized into the table. Again, patient information and consent is obtained. The pre-manip hold produces no adverse effects into the limb or in the knee. And then again, coming to the end range and a quick movement of the joint. This also could be accomplished by a quick tap to the thumb in that direction. These techniques could also be done with the patient on hands and knees. This position I find preferable as the patient is more relaxed and their hip area is further away and gives me room to position myself at the exact angle that is needed to move that joint. A weight-bearing dynamic assessment of the superior tibiofibular motion can be done with the patient standing, again with the feet parallel, shoulder width apart, and performing the same axial rotation that we saw in previous assessments of looking at the ankle and foot region. What I'll be doing here is looking for a small but critical glide between the tibia and fibula that occurs with axial rotation of the entire body. I will be palpating the fibula head, particularly its anterior part, and a point on the tibia, just lateral to the tibial tubercle. And then I'm going to ask her to look over her left shoulder and pivot slowly and smoothly through her body, right down through to her feet, and then come back to the middle. And do that again. And when she left rotates, you can see there's a slight separation between my fingers, my thumbs, and back to the middle. Now she's going to look over her right shoulder and pivot to the right. And you see a relative movement of those two bony prominences coming closer together and back to the middle. And again, pivot to the right. And relax. It's important with any palpation between two bony landmarks that you stay anchored on the bone and ignore relative motion of soft tissue, fascia, and muscle, and stay focused on the movement between the two bony prominences, which will not be this large. It will be a small but important movement.